Okay. Thank you, everybody. Just a couple of things. I came here when I was 21, and so a little bit older than that. And I've been to Seattle for the past few years. Of course, University of Washington brought me here from the Bay Area. Just to give you a little bit of background, because public health has been my field since the time I came to the United States, so to speak. But I started kind of through the back ways, because I worked as a paramedic in Oakland, California during the crack epidemic in the 1980s. So that was my first-hand experience in terms of people accessing healthcare by means of emergency 911 type of call. And working in East Oakland definitely opened my eyes to see the realities that I wasn't aware of. Before I came to this country, my background is actually in political sciences, so it was a big switch for me to go into healthcare. But one thing led to the other, and I have over time have variety of experiences in the field of public health, and then most recently, of course, because I have a health administration background as well, I've been running a community health center here in Seattle for the second time. But I just wanted to give you that, sort of like, so you know that, where I come from and all those pieces, how they play all together, and why this is important. What I'm going to share tonight is, I don't want to bore you with all kinds of data information, because I pretty much believe that most of you are probably well informed. But I just want to walk you through the primary care system, which is basically what is close to what I do, because it compares a little bit to my daily activities when we provide services to people, low income communities, quite diverse, and accessing basically family medicine. So I brought a PowerPoint presentation that I put together for a previous presentation when the first secretary of the Cuban embassy in Washington, D.C. visited Seattle. And I was asked if I wanted to share something with a group of people that were coming together at Seattle University. And I said, all right. And I had to change it a few times because I thought I was going to talk about something, but something else had to do with the embargo. But I ended up talking about primary care. And it made more sense for me because that's closer to my heart and my experience. I'm not an expert. I did some research in order to put this together. Of course, my background in public health allowed me to be exposed to all different kinds of health systems around the world when we're looking at the United States in terms of developing countries. But Cuba always stands out because it's a small country in Latin America, and yet when everybody hears about it, they always hear good things in terms of indicators, health indicators. Compared to, our system, which basically does a lot, spends a lot, yet it manages to be 24th in the scale of all these countries, and Cuba is right there with them. And this might explain to you a little bit why that's the case. Before I go into detail, how do I do the... David, how do I make it bigger? Oh, it's okay for me.
I'm not. Oh, for you?
Oh, it's okay. So never mind. I have my notes. I can do it. First of all, since I'm not going to go into the history of Cuba, I'm not going to go into the whole evolution of the healthcare system. I'm just going to talk about primary care. I just want to ask you, how many of you are familiar with the history of Cuba since 1959? To now. Great.
Kind of.
Thank you. And what about pre-1959? Few hands. Well, the reason why I ask you that, because it's always good to put it in a context of in historical context. So when you see some of the information here, it explains a little bit why that happened. Since I come from Latin America, we share the history in terms of having dictatorships, having military governments ruling countries over a period of time, and we definitely have all these issues regarding health disparities, income inequalities, as well as civil wars and disappearances, death squads, all of those things. At least I lived through that. Cuba, on the other hand, in 1959, of course, for those who know, they had a military person ruling the country. They did have major social and economic inequalities and disparities happening. So, and it was, it's 90 miles from Key West to Cuba, and it was basically like like going to Vegas, basically a destination for people, affluent people who had a lot of money to spend. But if you actually travel in the countryside at the time, probably would be no different if you go to Honduras today in the countryside, in terms of living conditions, in terms of poverty, in terms of access to fresh water, access to health care, basic services, etc., etc. Just wanted to say that, so give you a little bit of a context. So Cuba and the U.S. relations, family medicine, public health. And that's why it's my intention to be able to share with you. Forgive me, I'm not going to have pictures or a lot of data or anything like that. I'm just going to walk you through as I have done with other people that share with me this information. First of all, we have to understand that in 1959, after the revolution, there was definitely an effort to bring, especially the people who started the whole political process in the countryside, realized that by the time they actually made it to the capital city, they needed to look back and go to the basics and start thinking in terms of what's the life of the people who actually live outside the major urban centers. So at the time, Dr. Ernesto Che Guevara, which everybody knows, Che from Argentina, actually was part of the process. He was a medical doctor like some of you. He did a speech in Havana in 1960, basically laying out the basic principles of what health or public health or basic health care should look like, considering the conditions that they were at the time. So in his speech on revolutionarymedicine.co, you can actually find it on the web, both in English and Spanish. It stated those 3 points. He wanted to make sure that public health services need to be accessible to as many people as possible, because he witnessed the basic and dire circumstances that people in remote areas actually live. He wanted to definitely think about instituting a program in preventive medicine, because he saw the value that before we actually get to the hospital, it's better to keep people healthy. So as an individual, I can appreciate that. And of course, when you look at the living conditions of people, which is the public health concern, you want to make sure that everybody has an understanding and knowledge about basic hygienic practices in order to prevent disease and disease spreading. A little bit of a background. So I'm switching from 1960 to 1976. A lot of things happened, a lot of evolution within that process. Not everything was perfect. Not everything was ideal. It was a lot of work and basically bring people together. One of the first things that happened, like people needed to know how to read and write. And the literacy campaign that took place in the 1960s definitely laid the ground for bringing people together to the point that now we have like probably 99% of the people in Cuba, in the whole island of 11 million, know how to read and write. Nothing can be compared that to any other country in Latin America. I can say that. So after all these periods of evolution in terms of what should health look like, in 1976, combined with the 1983, the 1976 Constitution adopted, and then in 1983, kind of an amendment process that they went through, defined what healthcare should be for the country. And as we all know, at least here in the United States, when we hear about what we would like to have, the very first item over there, healthcare should be a right for everyone. It should be available equally to everyone and should be free of charge. He wanted as a country, they wanted to make sure that the healthcare was the responsibility of the state, just like Medicare and Medicaid is in this country. So it's no different from that, except for everyone. All specialties and preventive care, family medicine, all should be integrated, should be part of the whole experience of accessing healthcare. But we, as public or the people, should be active participants as well, because as part of the social movement that took place, health is a component, of course. Everything else has to do with the social organization and integration of the communities. So this fit as part of that overreaching goal of the society. And that's why you see that economic and social development is part of health, and it should be all integrated. So if I'm a medical student or I'm a worker, we all should be aware of what is our common interest when it comes to health. Public health, global health cooperation is a fundamental obligation. As you probably all know, there are a lot of doctors, Cuban doctors, across the different parts of the world. The most recent case, the Ebola response in Africa, probably was one of the first countries, aside from Doctors Without Borders, that actually sent medical doctors to the center of the epidemic. So that's part of their core values. And then public health integrated clinical practice, very key, because public health or health surveillance is key in order to maintain overall population's health. And disease prevention, which is part of public health, equals or equates to the overall health of the people. So when it comes to the health system, I'm thinking in Latin America because for us, Cuba is an example that things are possible, that we share common culture, history, and language, and we know by looking at their history there is a possibility, there is a possibility when people come together that things can actually change. We all have a common goal, and especially when you are living under circumstances that basically it's very obvious that something needs to happen. So in the basic premise of the system itself, when we're talking about medical and public health system, we're thinking that basically they wanted to create a high quality primary care network. They wanted to have an educated workforce, and like I said, literacy was one of the first elements of that. Because of all of the economic circumstances, which I'm not going to go into, but how many of you know about the U.S. embargo on Cuba since 1961? Pretty much everyone. That means basically, just to give you an idea, when we hear the word embargo, means that they cannot actually do transactions, commercial transactions, with countries around the world that may have any connections with the United States. So basically, we have gone out of our way to make sure that economically they don't thrive. And I'm not going to go into details on that, but basically, it's the only country probably that we actually have sustained it, maintained it for over 55 years. That's why when you look at sustaining a local biomedical and research infrastructure, that has been a key for them. Not only because they need to manufacture their own pharmaceuticals, in some cases access to basic medications, but also has become a source of income that they can actually export to other countries in the world. And that has been very meaningful because they're very economically dependent of many, many things, but that's another story. Definitely their idea, when you live in an island, you want to be able to control infectious diseases like anywhere else, and you want to always be able to eradicate or eliminate as much as possible all the communicable diseases. And also in meeting emergency health needs of less developed countries, like I just mentioned the example of the Ebola outbreak in Africa a couple of years ago. That's a good example, but there had been many others, including Katrina, when basically the people in New Orleans were experiencing such a dire circumstances. Cuba was one of those countries that offer, with no charge, that is, to send medical teams to be able to help the poor communities living in the aftermath of the Hurricane Katrina.
Was that
In New
no.
Beg your pardon?
That was rejected by our government, right?
Oh, yes.
Oh, yeah. Just
Yeah.
clarify.
Oh, yes. Um, I work at a community health center, and of course, we are a healthcare organization that provides, like I said, services to low-income people and multiculturally, linguistically diverse populations. And more, and as being a student of public health and being a professional of public health, we hear now the term social determinants of health. What we're saying is that health is not all related to me going to a doctor and getting cure or getting a medication or anything like that. Health overall means that the social environment, my economic condition, my sense of self in terms of the community, my overall sense of neighborhood and relationships, my ability to access healthcare without having to worry about how much money I have to pay, $5,000 deductible I heard over there. All of those are stressors that basically contribute to ill health that may not be manifested at one point in an obvious way, but over time can accumulate and definitely can manifest in multiple sorts of ways that sometimes we don't even have an answer, and we always challenge but what that might be. So more and more we're hearing about paying attention and trying to determine what those social determinants are for our communities here in this country, as way as to address them as much as we can to be able to contribute to the overall health of the people accessing healthcare, at least when I'm thinking at the health center that I work for. In Cuba in 1974, community medicine was basically that. Part of the education was to incorporate the idea that medicine is not just what we normally think about it, but is an integrated health approach that takes into account the environment, your biology, your social standing or situation, and any kind of psychological factors that may be affected by the environment that you live in. And all those are part of the overall contributors to one's health. So right there and then, if we have already people going through school thinking along those terms, that makes it kind of opens people's mind to how we actually address issues of healthcare. I use this. This is something that I also have come across in my profession when I hear community-oriented primary care, which is basically what I do. This is a term that basically came out of the 1950s and was put into practice in South Africa, actually. And I put a quote here because it's a way to describe it. It says that a systematic approach to healthcare-based principles derived from epidemiology, primary care, preventive medicine, health promotion, that has been shown that has positive effects in the communities in the U.S. and worldwide. That hasn't changed. Those are the basic principles that I've been hearing ever since I set a foot in this country, and I became part of the health profession. This is always basically everybody shares those values. How those play in the reality, that's a different story, because here in the United States, everything is tied to finances, and we have a system that has multiple sources of finance mechanisms that sometimes is very hard and challenging to understand, but nevertheless it determines actually the course of many of the activities that take place in the way we deliver care. So the feasibility and external funding, both private and government, they fluctuate over time. So like grants, sometimes they're here, we do some good work, they go away, another interests become of importance, and then whatever work has been done, it has to, it gets put on hold.
Prove it works and then the grant's over.
Yeah, exactly. Just like when we go in international mission somewhere and we do good work and then we leave feeling good, but then the people there still remain. They don't have the money they needed. We run out of money, and that's it. Same thing, except that this is happening here. Education, as I learn, even though some of those elements are still part of the educational system in medicine, medical school, there has been many difficulties or challenges to trying to incorporate them uniformly across all schools. So depending where you go, depending on what type of medical school you're getting, you might be able to be exposed to some of that. Surprisingly enough, some residents that came through my clinic, when I asked them a simple question about what can you tell me, or how many classes or how many hours do you spend understanding how the U.S. healthcare system works, and this is while I'm touring the clinic and explaining to them what we do, they look at me puzzled, and they said, well, 3-hour class, 4-hour class, oh, it's just an elective, oh no. So basically, and when actually I challenged them a little bit more, at one point I said, well, can you tell me in terms of what you're going to be doing as a doctor, and how's that going to work in terms of people accessing care? And they have no idea. They have no idea. So that highlights the point that medical education is important, and what we include in that as part of that education, aside from the understanding of the body and the physiology and the anatomy, unfortunately is not happening. But in Cuba, of course, that has been successfully implemented, and that's why it's such a good example for a lot of countries in the world, because physicians that actually work in the community are held accountable by the work they do, because they're part of the community themselves. And you're going to understand a little bit more as I walk you through and how that actually works. So in 1976, the Ministry of Public Health, after all this evolutionary process, defined the health professional training and defined the basic principles that they wanted to actually make sure that it was part of education, have a basic knowledge base, competencies, and scope of responsibility at each level of the university level health sciences. So that in itself, by 1983, when they actually did a pilot program in Havana that was successful, then started linking all these different services and be able to have more coordinated care. Not to say that the whole system evolution has been perfect, because we're always going to have issues of, oh, I wait too long to see my doctor, or I wait too long to get an appointment, or things are not as fast or ideal as I would like to. Well, welcome to the club. Everybody has to go through that, and that's part of the imperfections, and that's the part of the learning process of the system as it evolves. In Cuba is one doctor for every 600 people.
Yeah.
So the question is...
Family doctor.
Huh?
That's a family doctor.
Family doctor, yes. What about in the United States? How many of you can tell me how many family care doctors are there for how many citizens?
It's about 1,800 now.
About 800. So, 3,200. And that was in 2004. So, basically, going back to the 1983, when they actually started piloting the nurse doctor team, basically, that was kind of the starting point of the family practice, because then they were able to actually work in neighborhoods. Well, actually, what I have to say is that was the linkage to secondary and tertiary care. So having that in place, they were able to, you're going to know a little bit more about what a polyclinic is, but basically it gives you an idea that there are teams of people working in communities, medically speaking, teams of medical professionals working in communities that are very well connected with the various polyclinics. So people, regular citizens accessing healthcare, can actually feel comfortable enough that their care is going to have a continuity from the moment they see a primary care doctor, if the need arises to go to a specialty, all the way to the hospital. And I'm going to talk a little bit more about that, because obviously emphasis on when you are in a situation where you want to see people, you want to prevent as much as you can. By the time you get to tertiary care, we're talking about a very expensive venture. Here in this country, you probably all know very well what I'm talking about. I'm not going to go there. Yes, ma'am.
I'm curious about dental care. Is that considered health care?
Yes, ma'am.
Is that included in what?
Behavioral health, psychological, everything. The whole body. The whole body. So, and Sokhshil might be able to correct me if I'm wrong, but the national system at the time determined that definitely we needed to have an increased proportion of epidemiological and public health sciences. basically they wanted to think in terms of health and population, not just the individual, and they wanted to be able to have people train, people going through health training to be aware of the social conditions of their community, be able to actually have active learning methods, they call it, because they wanted to be able to actually bring it all together along with the clinical skills and their biomedical sciences. So not sciences alone, but actually have the social aspect of it as part of their training. So public health and clinical medicine combined into one single profession. So when I went to public health school of public health here in University of Washington, there were only a few medical students that came through and received that training. That was an elective, that was a choice. Part of the education, according to what I found, it is part of the medical education already to be aware of what public health is, because it's going to make sense once they actually practice. Sakshil is a requirement for all the medical family practice residency as part of your education. Yeah. So that means that regardless of what my specialty is going to be, that means I'm going to spend some time practicing medicine at the family level, primary care. So family physicians are required to look at patients in the context of family and their community, and they do actually keep records according to family. So if I go to the doctor, my mother goes to the doctor, and we all go to the doctor, it will be under my surname, but the whole family will be as part of the health record. So basically, here it is the situation where we have all this information coming through the primary care clinic, and all this information is going to be part of the neighborhood, that it's going to be combined with all the different other clinics that there are, and they're going to be centralized so they can actually capture that information to assess to the overall health of the population. So in a way, they're practicing medicine, they're dealing with one-on-one issues in terms of symptoms and treatment, but they also are tracking the overall health, and they're also participating in the process of determining if there is any issue of concern, a particular group of people that may be affected, so they can actually collectively think in terms of what could be an approach if something that needs to happen at larger scale. And that's basically part of the integration of public health and family medicine. The last thing that I wanted to say about this, and I'm going to talk a little bit more about how public health officials actually do their work, but the complementary and alternative medicine is another aspect of the fact that since they don't have, because of the embargo, they haven't had access to all the pharmaceuticals that we have here. Alternative medicine is an alternative source of healing, basically. So they have part of their schooling, natural medicine or that sort of thing, because at one point during the special period at school, there were very few pharmaceuticals available. So they have to make the best with what they have. So medical students had to learn about it because they were going to have to deal with it when they were actually practicing. How they go about assessing in terms of how effective are the work that they do? Well, there is a constant, it's a process basically that is kind of, it goes in cycles, that it's a continuous assessment. We basically, when we deal with issues of quality in this country, we always think in terms of how we can do things better, and we have all these different names and things we go by it in order to make it happen. But here they have a name, and in English is the continuous assessment and risk evaluation. So this assures that the patient medical history, the physical examination, the whole environment, the neighborhood, the whole social determinants of health, so to speak, are accounted for, and residents then are individually can be then further categorized in 5 different groups or 4 different groups according to risk factors. So that way they can actually prioritize depending of the level of health needs. And by that, as you can see, it can be chronic diseases, which is the most common, and then some behavioral ones related, but then you have issues like we have here in terms of one thing might lead to another. Nutrition is the case, overweight, hypertension, diabetes, etc., etc. So they're looking at from the preventing point of view, they want to address it as soon as possible, rather than actually wait until it gets too late and then you have to have people on their medication. Because that, again, it balances out with the economic situation they actually have to face with. They don't have access an endless amount of dollars that we do here to spend for chronic disease treatment over time. It is time consuming. Like I said, family by family, records are kept by family, and they're done on paper, right? No fancy computers, no all these computerized systems that we have here everywhere. Everything is done by hand. It's tedious, time consuming, but doable. Reality, that's the reality. I am going to go ahead to tell you that then how it happens. Well, doctor and nurses work as a team. They live in a community. Many times could be a little, space, but maybe has an apartment above. Maybe the doctor lives there. The nurse lives nearby. They are very well known by the community. The residents, for the most part, the doctors may stay there for part of the residency, may stay there longer after the residency. The nurses actually are the glue of that team because they tend to stay longer as part of the community. But for the most part, everybody knows each other, so the team of doctors and nurses working are basically available almost 24/7 because they happen to be part of the community they live in. Each team is responsible for improving and maintaining, not just providing healthcare or seeing people on a daily basis. They actually are responsible for the overall health because the part of the tracking is going to be part of the evaluation of the care that they're providing is going to be based on the care on the overall health outcomes of the people that are receiving care through the clinics. So they do yearly visits. At least once a year, a doctor will go to people's homes. Nurses probably doing a little bit more often. In cases where chronic diseases or you're discharged for the hospital or something like that, then the visit may happen more often, maybe happen once a month. And then all the care will be taken care of home. Referrals, diagnosis, and specialty consults, they are very tied together, just similar to what we are here, except that if I refer a patient here to Swedish, I don't know who the doctor might be. I have no idea who might be next day. I just know that he's going to come to a specialty care appointment at Swedish.
If you're lucky.
If you're lucky,
the time
right?
They don't take their insurance.
What I'm trying to share with you is that in the case of Cuba, I'm the primary doctor. Might actually have a relationship and know person who is at the other end of the specialty, and they can actually come together at one point and talk to each other. So they can talk about the patient in more of a familiar terms rather than just another patient. They do follow-up visits at the hospitals, just like we do here, and all the follow-up treatment after discharge happens at the neighborhood clinic. And that's part of the coordination of the health services. Both the physician, the family physician offices, or those clinics, neighborhood clinics, basically, as we link to the polyclinics, that's the term with basically all the specialties are. They're supervised by them by a team of people. Each team supports 20 to 40 family physicians and nurse teams. The basic work groups, they call it, basically are composed by a leader within the polyclinic. They have a nursing supervisor, an internist, pediatrician, obstetrician, gynecologist, psychologists, and many other social workers. So basically they all come together and they assess for what is happening at each one of those clinics.
A lot of those
Exactly.
pieces that-
So physically, yes, you have it. Now, because we're talking about coordination, when you actually have all these multidisciplinary teams working together and looking at the overall health of the population at neighborhood level, then that's an opportunity for everybody to exchange as best their knowledge and their ability to address any kind of issue that may be happening to any of those family members, depending on, because they're all very familiar with their, with their health records. Let's put it that way. So those basic work groups, they review and analyze the overall health of the neighborhood, and they actually perform the evaluation of those doctors and nurses working at that level. So they act as, when we say supervisor, their supervisors are basically their colleagues, and their measurement of success is the health outcomes of the population. So they're getting constant feedback that way. Of course, it has to happen. The only way this can happen is with the community participating, because otherwise it will never be possible. So the community support is very, very key. So the family and nurse teams, because they are integrated as part of the neighborhoods, and the people after 1959 socially became organized and collectively having a view of their communities in a different way that we do here. They are able to actually have other level of social organizations that allows them to respond to any kind of emergency because of the different situations that they have lived through. But specifically to the medical, that it is important for them because they also are going to provide opportunities. The doctor and nurse cannot do everything. If they need to, I have here sometimes diabetes classes. I have patients coming to the clinic, receiving information about diabetes in one room at one point, but one professional. So they all can receive that information at one point. There, it happens at the community level. So if we are all part of that community, who knows? We all probably have each one part to share information with the rest of our neighborhood, our neighbors, so we can all learn about whatever that might be. Malaria, Zika, diabetes, whatever it is that we need to do collectively in order to address some of the health concerns that might be affecting our community. Well, think about it like if I live in Ballard, that would be my community.
I got you.
If I'm in Ravenna, I would be, in my block in Ravenna where I live, I'm supposed to have emergency preparedness, awareness, discussion. So in case of an earthquake here in our area, we can always come together and share flashlight, water, whatever it is. That will bring us together as a community because we will be without electricity, without water, without gas. But kind of a preparation of that, it brings together kind of a neighborhood response. So that's an opportunity, at least in my experience here in this country and in this city, and how those communities come together. But think about it in terms of neighborhoods, because also the community is the one who we're all going to be able to comment or grade or evaluate or provide feedback to all those doctors and nurses serving in those communities as well. That is going to be shared with those group of people, the basic groups that we were talking about, the polyclinic levels, so everybody is actually part of the whole process. Public health and medicine, how that comes together. Well, in my experience in public health, we're always looking for any way of preventing any kind of diseases, either be flu, either be preparedness, could be waterborne diseases, it could be food poisoning, could be all sorts of things that affect the health of the public. We have a public health department, and that is actually responsible to track some of those outbreaks so they can inform us as a community as to what we need to do or how to prevent it. Well, same thing there. Same thing and same basic principles of public health. Basically, they want to maintain population's health, but also because they are also integrating the primary care, which is unlike what we have here, then they're able to actually look at issues of diagnosis, ambulatory services, hospitalization, so they're able to track all that information. And of course, develop always in terms of the community base, any kind of rehabilitation. Yes, and it's integrated. So yes, it's like if I go from one visit to the next, I saw one person or another here in this country, they may take a couple of days before they figure out what happened. here in Cuba, because it's part of the neighborhood, it's part of the community, it's part of the polyclinic, it's all integrated, and because they do it all manually and keep it by family, and they're responsible, and they are basically evaluated by it. So it is of a great importance for all that information to be shared and be part of the overall picture of so if you need to go to that class because of your particular health experience, it would be well known. Public health practice, I'm not going to much into it, but definitely they have spent a lot of they invested a lot into the overall structure, because it is of best interest when you are dealing with economic situation where basically realize that the value of preventive care is more affordable than any kind of tertiary care. So on public health, definitely being part of the education. I'm not going to go already talk to you about it. I spoke a little bit about this. Basically, this highlights the fact that because they keep records and they are responsible for the communities, then the communities are diagnosed. From the public health point of view, they're able to follow, they'll be able to analysis because they have access to all that information at the neighborhood level, at the community level. So, and they're able to plan accordingly because from the patient records, the challenge sometimes here in the States is to be able to actually to have accurate information, because we have all these laws in place and we have to do searches, so we have to spend a lot of time doing research in order to extract valid information that we can use to highlight what the public health, overall public health is there, because everything is seamless and integrated. They're able to do it, even though it's painstaking and on paper, but they're able to do it more so in detail and much more effectively, in a sense that they're actually more specific about the overall health population based on the neighborhood. Again, public health, community, be able to teach, opportunities, issues of anything related to communicable diseases, overall health. But they also have the part of the assessment, the epidemiology piece, which is population-based, again, by neighborhood, and the collaboration, which is part of the collective belief of how they actually go about it. And they actually can, I have actually access to Pan American Health Organization. Actually, Cuba is part of it, and they share that information. It's amazing the amount of information and detail that they actually keep track of the overall health of the population over time. Which is basically illustrated by their data collection and evaluation system. I'm not going to go much in detail on this, just to give you an idea that they do have a very well-established system by which they collect the information, process it, analyze it, and distribute back for the national purposes, but back to the community as well, so they can actually address it at the community level. Because ultimately, they're evaluating the health outcomes, and they're actually evaluating the effectiveness of the care people are receiving, or the interventions that they're actually sharing with the community. How come they're able to achieve all of this? Well, when you are in a situation of need, many times we realize that we have to do the better we can with the little we have. So the best we have in this situation for them is like, how can we do better? Basically, the question is, how can we do it with limited resources that we have? How can we achieve a better health outcomes for the people that we are sharing this island with? So Cuba is a poor country, as you know. Like other developing countries, compared to any developed countries, they'd be considered poor. They have very limited resources, the embargo being one of those issues. The health expenditure, they spend $600 per person per year. You know how much we spend in this country per person per year? Can any of the students tell me in terms of healthcare? If I were to give you dollars right now.
Your healthcare premiums are more than that.
Yes. Give me, I guess. Anybody knows?
Isn't the average around 8,000?
We're gonna hit 10,000. 10,000. When I was at the school, public health, we were like about what, 6,000? So that means that I can give you $10,000 to each one of you. You can do that to use for your health care for the rest of the year. That's how much money is. Now, in terms of the GDP, for them, it's like about 8%. For us, is what, like 20%? Almost?
17%.
About 17%, that's right. I'm exaggerating a little bit. But you know, the GDP of a country like Cuba, and I don't think I have it there. Yeah, they have $80 billion. Anybody can tell me what is the GDP of the USA?
It just hit 3 trillion.
Exactly. So when you look at those proportions and you look at the amount of money spent, comparatively speaking to the amount of the GDP of a country, and you look at how much they're spending per person and the health outcomes, you realize, oh, where is the magic? Yes, ma'am.
I just want to say the glaring thing that everybody probably already knows is the reason our healthcare system is the way it is by design. It's for profit. We aren't following
Yeah.
this. How can we do this? So it's not that we're just disorganized.
I know. I know.
It's by design. And it's,
I know.
It's a disaster.
Even with the Affordable Care Act, I mean, we still have 20% or so people uninsured.
Well, and a lot of the people that are quote unquote insured are these people with these ridiculous
Yeah.
deductibles who are for all practical
Yeah.
purposes uninsured when they
Partially
come in.
insured, that's right.
Well, they're uninsured because they don't own anything and they can't afford to get to their deductible. They come in one time and they get a $300
Yeah.
doctor bill to come in for a cold, and they're like, I'm not going back.
Exactly. Challenges and opportunities. Obviously, the embargo is a major challenge, and even with the most recent visits of, the opening of the U.S. Embassy in Cuba, the releasing some of the restrictions, the charter flights or cruise ships and visit Obama to the island and all of that doesn't change the essential fact that the U.S. Congress needs to be the one as a part of the government to remove the embargo to Cuba, and that would be a major change for what the economic conditions in the island. In the meantime, they still have to deal with that. They're dealing similar to us, an aging population. That's in terms of health. That's one of their challenges. People 65 years or older, because that's obviously, as we know, it costs more. Chronic diseases as well, any kind of rehabilitation. They balance it out because, like I mentioned before, biotechnology has been something that they have developed, and they are able to bring some income to the country to balance it out. Since 2010, the National Health Service, they want to always, in their constant reevaluation, effectiveness and efficiency in healthcare levels, which is basically what we hear here. They want better patient-centered and population health outcomes, just like we do here. They want to reconfigure systems as necessary. The big difference, of course, somebody mentioned it. Here we have all these different parts, private interests and so forth. There they have a national health system, which is a major distinction. In the year 2000, compared to 25 other countries in the Americas, when they actually look at United Nations Development Program, look at all the various indicators, Cuba was the only country that has the best health situation in Latin America and the Caribbean, and has achieved the most effective impact in the resources. I mean, through their scarce resources, they're able to achieve that. I don't know, anybody knows about the Healthy People 2020 goals, or over the years have been Healthy People goals 2005, 2010, 2020? Everybody knows? Well, basically those are the overreaching goals that here as a society, here in the United States, we will like to achieve in terms of health outcomes for the population, and it's always kind of a goal that we strive to, different organizations, to achieve. Unfortunately, we have never reached that. But it's there somewhere. Cuba, on the other hand, if we were to measure against those Healthy People 2020 is now, they're already there. All right. Affordable Care Act, I brought this because this would bring it a little bit closer to home. We did pass a law, Affordable Care Act, that is, a few years ago that aim at bringing people access to healthcare through different kinds of, still the same insurance scheme, but trying to bring them closer to the system. I'm not going to go into that detail, but basically Medicaid and Medicare probably are the ones who benefit the most. At least from my perspective at the clinic, people accessing healthcare through the Affordable Care Act has made it possible for a lot of people low income to be able to access, but they still have to face high deductibles and high premiums as well. But it's one step in a different direction. There is always the issue of financial incentives. Basically, that drives all the activities when it comes down to healthcare in our country as we know it, because we do have a private system. And obviously, they want to improve health outcomes because we know that health in this country costs a lot of money, so they want people healthier, so we don't have to, it doesn't cost us much, but it's always the same, basically, formulaic approach. Accountable care organization like mine, which is a community health center, is something that we are looking at the populations of Medicare and Medicaid, and we are accountable for the overall health outcomes of that population by following certain standards and measurements that are going to give feedback to the people who actually fund the system, so then they can actually then plan for future funding. So basically, our assessment, the assessment of the health of the population, Medicare and Medicaid, we have all different kinds of indicators. It's an aim of the Affordable Care Act to be able to make sure that we actually are doing the right thing for people and they're manifesting in good health. I'm going to say the lesson in terms of the healthcare delivery system in the United States. Short of adopting a national health policy goal to match Cuba's, there is something in the Affordable Care Act that brings the concept of an accountable care community, which is basically the concept that I highlighted in terms of how the system in Cuba actually takes place and how the community participates. There is an element of that in the Affordable Care Act, but again, without financing and support and coordinated efforts, it's still just a theoretical concept. And of course, we always want to achieve better health. In terms of the U.S. National Prevention Strategy of 2011, the basic concept of what we're talking about is basically 4 evidence-based strategic directions. And this is similar to what I, as a community health center, we are dealing now. Expand quality of preventive services for both clinical and community settings. Eliminate health disparities. Empower people to make healthy choices. And build a healthy and safe community environment. So basically, the basic concepts that I started with that are the social determinants of health. This was put together as part of the Surgeon General back in 2011. In Cuba, these strategies already have been in place for many years, so that's something that when we look at thinking in terms of we are defining something new, perhaps it's not so new, perhaps it's new to us, or we are wording it differently, but if we look outside our country, we can find other examples, and Cuba would be one of them. Populational health, clinical prevention and populational health curriculum framework in medical schools. That has been tried in medical school, these subjects, but they often have been omitted because it's always an issue of competing interest, and it's always the issue in terms of depending what school you go and how the profession is defined that determines what the content of the curriculum is going to be. Cost, always the issue. It is difficult to maintain it and to secure time and resources that are required for that integration of that part of the schooling. Local health departments, they're trying to do their best, they're trying to support, they have served as safety nets. Unfortunately, funding actually fluctuates, and they used to have clinics, now they don't. They used to have nurses, now they don't. They do provide some basic services here in King County, but not as much as they used to 5 years or 10 years ago. always funding has to do with what the priorities are, and that's how the public health department actually operates. Another lessons, all the stuff that we talk about in terms of chronic diseases, we have all these different organizations, the Heart Association, the Lung Association, the Diabetes Association. Unfortunately, they don't talk to each other. They all do bits and pieces everywhere. They have their own funding, they have their own interests, they have their own groups, and then diseases are looked at just like one group, and another group. Ideally, if those can be integrated, that will be part of that community effort that will bring the overall health when we think in terms of a national healthcare for us here in this country. Universal access. Not expected in our country to have one because we always seem to be afraid of, at least not us here, but some people in the country, except for the government finance systems like veterans. The Veterans Administration, basically all the people who serve in the military have free access to health care, and they have continuous care. Medicare, Medicaid, another government finance system. But without that universal access, which is the backbone of what happens in Cuba, I think it would be very difficult for us to match what they're doing or the health outcomes they have achieved. And single-payer system will likely be the most cost-effective approach, which would be an example. Medicare probably would be one of those good examples. Bernie Sanders is talking about it in that context. But still, we don't have enough information, or we at least, some parts of the population are not fully informed in terms of how the system works. So unfortunately, that gets in the way. Lessons for medical students. Medical students here in the United States, by the time they finish school, they earn a lot of money. It costs a lot of money to go to school, depending of what specialty, or if you want to be primary care doctor, $50,000, $60,000, $70,000 at the end of the education. Not everybody wants to be a primary care doctor. Everybody wants to be a specialty. That's why we have a shortage of primary care doctors in this country. They have to pay the debt. They have to pay $100,000 by the time they're done with the school. So it's competing. In Cuba, of course, the model is to be able to bring people from the community so they can actually work in the community. A good example, the Latin American School of Medicine, same principle. If I come from El Salvador, I work I'm of a humble background. I have enough passion for the profession. I might be able to qualify. I go to the school. I become a doctor. I'm eager to go back to my community and work and do my best for them. So Chile is probably one of the examples of that, and in her future career, that would be her opportunity to do so. Here in the States, unfortunately, that's competing interest, financial interest, that is. But it would be one strategy that can help how the system change. Has to start with education, and medical education, I think, is the heart of this. Next steps. What can we do in order to get even closer to find a little bit more of what would be like to have the level of health or the assurance that we don't have to worry about healthcare like in Cuba? Citizen action. Without organization, without community organizing, with people coming together and sharing same interests and goals, is very difficult. How that is manifested in voting, civic action, is the only resort we have here. Unfortunately, I heard that in primaries here in the state of Washington, can anybody tell me what percentage of the eligible voters actually voted for the primary just 2 weeks ago here in the state?
Like 5% at most.
Thank you. Yes, between 5 and 7%.
We
So, and compared to other developed countries, by the time we'd go to presidential elections, 30% of the people voted? Compared to other countries in Europe that are closer to 100%, or other countries like Australia, which is required to vote. Basically, as citizens, you have to vote.
Your vote counts.
Beg your pardon?
Your vote probably counts, whereas we don't really have a democracy.
Well, if we actually have the numbers, it might change some of the attitudes about it. Because when they see, oh, only 3% voted, I mean, look at Trump. I mean, how many people are voting? What percentage of the population is he representing? Yet he looks like a big candidate. But when you look at it in the context of the whole country, you realize 300 million people, how many people are eligible to vote, and you see the number of people that are voting for him is very minimal within that party. So, political will and accountability. So we have the power to vote, we are organized, and we actually exercise our citizen right to actually express our political opinion through a vote. Then we can help people accountable. But if we don't vote, it's very difficult. They're still depending on the money they need from different sources to be elected one more time. And they don't need that many votes to get elected, as we know. So, having said that, I'm just going to leave you on a positive note. A picture of a wonderful, beautiful group of medical students, I don't know, just like Sochil. Very diverse, multi-ethnic, and a clinic which is nothing compared to the clinic that I work with in terms of the environment, clean, renovated, technology, etc., etc. Simple, humble, yet pleasant, friendly, and accessible. And in that picture you see intergenerational, also the connection between what the community should be. So, I'm sorry I took so long, but thank you very much for your time.